This is Chapter 32, the child with neuromuscular or muscular dysfunction. And we'll look specifically at cerebral palsy, spina bifida, the most common muscular dystrophy, and botulism. Now, cerebral palsy was a new definition was made in 2006, and it says it's a group of permanent disorders of the development of movement and posture that cause activity limitation. They're attributed to non-progressive disturbances that occurred in the developing fetal or infant brain. And we'll unpackage that a little as we go. So what do we have? We have abnormal muscle tone and problems with coordination. It's non-progressive. This is not something that's going to get worse. The muscles that don't work do not get worse than they've been. They can be pretty significantly impaired, however. So it's often accompanied by perceptual problems, language deficits, intellectual impairments. So we may, often these kids with CP, we see, they may be nonverbal, they may be blind, they may have, cognitive impairment. So all of that can go along with it. But the CP itself, we're talking about the muscle imbalance. Now, these kids, between 15 and 60% of the time, they'll also have seizures. And the book doesn't say it, but it seems to me the more severe the CP is, the higher the risk of having seizures. So, CP is our most common permanent physical disability of childhood, and this happens between 1.5 to 3 children per 1,000 live births. Now, probably about 80% of CP cases, we have no idea why they have it. It's an unknown prenatal factor, something that happened in utero. The pathophysiology, we see on these kids gross malformations of the brain. There may be vessels that are occluded, there may be atrophy, so the brain is actually kind of shrunk down, the parts that aren't working. And that happens with this loss of neurons and degeneration. Now, we have new data. In the old days, we thought that CP happened from birth trauma. And now we say that the majority of cases of CP are not a result of intrapartum asphyxia. So, lack of oxygen to the brain during birth. That's not the case most of the time. What is true is our premature babies, especially ones who are very small and very premature, have a much higher risk of CP. So there are some different classifications of CP. The most common type is the spastic CP, and with that you have increased muscle tone and decreased coordination of movements. So they don't have good, smooth movement. It's kind of jerky, big, swinging movements when you should do something small and fine. These kids very often get contractures. That's a big problem with your spastic CP. Another type is dyskinetic, where they have uncontrollable, non-purposeful movements, and particularly of the hands and face. So it's kind of just movement that, like the clonus you get in infants, except it continues on. Then there's ataxic, where they have an unsteady gait and poor coordination, and then they'll sometimes say mixed types, because it has characteristics of all of the above. The symptoms of CP. How do we find out or diagnose a child with CP, or how is a child diagnosed with CP? Because infants don't do that much, so how do we know? Well, that's part of why we're watching their developmental milestones. As we see they're not rolling, now they're not sitting, now they're not pulling up. As they're missing those milestones, CP should be one of the things that's being considered. And if they do make those milestones, but they're abnormal, so they stand or they walk on the toes, There's some feeding problems. They don't suck right. They don't seem to swallow right. They cough and gag. That should be a sign to evaluate. Alteration in muscle tone, and that can be either that the muscle tone's too much, they're kind of stiff, or it's too little, they're kind of floppy. And one of the real characteristic things with CP is the scissoring of the legs. If you take an infant and lift them up, kind of hold them under the arms and lift them up, a normal infant, their legs will hang down, or infants tend to stay in that flexed position, but their legs will be the right leg on the right side and the left leg on the left side. Kids with CP, they'll scissor the legs, where they'll crisscross the legs kind of at the ankle or the lower leg. Like if you're sitting and you cross your ankles, but that's the way they'll look when you lift them up, holding them from under the arms. Another thing is looking at abnormal posturing on an infant and abnormal reflexes. So if we see that they're asymmetric, they use one side more than another, that should be an indicator that we need to get them assessed. Or if those infant reflexes persist longer than they should, that Moro reflex, the startle there, that shouldn't go on beyond 4 months. And if those infant reflexes are lasting, the child should be evaluated. Aims of therapy: trying to get them mobile. So to establish locomotion, communication. Often that can be a problem if those muscles around the face and the mouth are affected, or if there's cognitive problems along with it. And self-help skills. So that's one aim. Another one is to gain optimum appearance and integration of motor functions. Another one is to correct any associated defects that go along with it that can be corrected, or correct them as well as possible. And then to provide educational opportunities that are appropriate to the child, so things they're able to do. And then to promote socialization experiences, both with affected and with unaffected children. And in our area, Break the Barriers, which is a gym where they do gymnastics, they have really focused on including children with handicaps along with children who don't have handicaps, and having them work together and learn things together. And here's a picture. We've got great adaptive equipment these days. Okay, therapeutic management. They may need surgery to correct contractures or other deformities that they have on the spastic extremities. Muscle spasms are a problem, and muscle spasms can be very painful, and some of the medications we use are baclofen and Valium to relieve those muscle spasms. You can also use Botox, botulism toxin A. This is, the same thing as for wrinkles. And what it does, it reduces contractures, or the goal is to reduce contractures in the muscles, but you give it as a little injection, just like for wrinkles, and it relaxes that muscle so you can do good range of motion and hopefully prevent the contractures. Remember, we said a lot of these kids have seizures disorders, so we need to have them on seizure medications too, and try and control their seizures. Now, our nursing care, we want to work closely with parents on kids like this. Parents are going to know what's normal and what's not for these kids, where if we're just meeting the child, we don't. We want to give them frequent rest periods. It takes a lot more effort for a kid to walk or talk or eat when they're using every muscle in their body to do that. They're just expending more energy, and so we need to make sure they get the calories as well as the rest that they need. And we want to find recreational outlets for these kids, things that they can do that they're going to be successful at and enjoy. Do think about protective equipment though. If they have a seizure disorder, we may need them wearing some sort of a helmet, or if they fall easily, we may need mats around when we have them do something. So think safety. Support the family. This is a permanent problem, so we're finding ways to kind of work around the child's limitations. So the family may need support as well as the hospitalized child. Kids with CP aren't usually admitted for the CP, but something else related to the CP. It may be corrective surgery, or they may have some breathing difficulties and they're admitted for pneumonia, but they also have CP. So it's not usually the CP that brings them in.